Well, good evening, everyone, and welcome to this evening's exciting Dermatology Rheumatology Collaborative, a focus on skin of color. I'm Samal Desai. I'm a board-certified dermatologist in private and academic practice in Dallas, Texas, and it's my pleasure to be your chair and moderator for this evening's exciting NPF webinar series. I'm going to turn it over to my colleague, Dr. Stacy Bell, who's the Chief Medical Officer of the National Psoriasis Foundation, for her introductory remarks. Stacy.
Good evening, everyone, and thank you so much, Samal. If you could go to the next slide, please, Shiva. So thank you. As Samal said, I'm Stacy Bell, and I'm fortunate to serve as the Chief Scientific and Medical Officer at the National Psoriasis Foundation. Thrilled to have everyone together for this program this evening. A big thank you to all of our faculty and to Samal for chairing this event. It's something that we have talked about for a long time to really bring dermatologists and rheumatologists together to address some of the issues of the underserved and the unmet needs overall in our community. Those with different skin types, those of different socioeconomic status, those of different geographical regions are things that we're really trying to focus on so that we can ultimately provide the best care possible and the best health outcomes possible. So for this evening's program, first, as I said, a thank you to our faculty. Secondarily, a big thank you to all of our partners. This activity is being done in association with Pac-Man and is sponsored or supported by educational grants or support from AbbVie, Bristol Myers Squibb, Janssen, and Pfizer. If we can go to the next slide, please. So this evening is an accredited event. The National Psoriasis Foundation is accredited by the Accreditation for Continuing Medical Education, or ACCME, and will provide this education to physicians, educational credit to physicians. In addition, if you are a non-physician, we will provide a certificate of completion, and that can be applied or filed with the appropriate accrediting organization for you. If you go to the next slide. The disclosures for this evening's event are on this slide. Go to the next slide. And I wanted to just touch on a couple things from an NPF standpoint. A number of you have reached out regarding our funding cycle for our grants and fellowships program that had recently opened. We opened the program on October 15th. Applications are due on January 15th. The program itself is a mix of our traditional granting mechanisms and our research fellowships and summer student awards, with a focus again this year on the More Than Skin Deep mental health program. If you have any questions or have any difficulties with the application, don't hesitate to reach out to me, and I'm happy to help you. We've gotten some phenomenal applications already, and we look forward to receiving more. If you go to the next slide. The next program that I'd like to highlight is actually our mentor program. So we are very fortunate to have faculty here this evening. We are even more fortunate to have a wonderful community of both dermatologists and rheumatologists that not only provide care and conduct research, but are willing to, be mentors for those starting in their career, those that are serving as students at this time. Our mentor program is very diverse. You may serve with a peer, you may learn another specialty, you may learn from someone who is younger or older, or I should say earlier or later in their career. And this is something that is completely sponsored by the National Psoriasis Foundation, either being conducted in person or virtually, like we are all getting used to at this point in time. And so again, more information about our mentor program can be found on our website. Go to the next slide. Also, as just a summary of the benefits for professional membership, programs like this evening are free of charge to attend because of our very generous donors and supporters, but also because of our member network. There's several benefits that go along with membership of the NPF, such as annual subscriptions to the Journal of Psoriasis and Psoriatic Arthritis, access to patient data, access to patient educational materials that you can use, and then also ways to really promote your clinical studies and your clinical practice through our healthcare provider directory, through information through our patient navigation center. So with that being said, I will turn it back to Samal, and we'll go to the next slide.
Well, thank you very much, Stacy, for those introductory remarks, and a special thanks and my gratitude to the National Psoriasis Foundation and all of our partners for committing to put together this event As I mentioned in my introductory remarks prior to Stacy's slides, this is a collaborative effort between dermatologists and rheumatologists. And I think that's the beauty of tonight's event, because we're really looking at the entire patient. Tonight's event is focused on skin of color and health issues in our underrepresented minority populations, and we have a robust agenda, as you can see here tonight. I'm going to kick it off with our first speaker in just a few moments, but let me also mention that we will have two Q&A panel discussions. And as someone who specializes in skin of color in my own dermatology practice and in my research career, I'm really honored to have this fantastic group of faculty. These are all renowned individuals in their own right, well-published, really thought leaders in this area. We have 3 dermatologists, 3 rheumatologists, and you're really going to hear from a really great cadre of professionals tonight. I'd like to kick it off with our first speaker, my friend and colleague, Dr. Erin Bowe. Dr. Bowe has been an academic dermatology and a leader in our specialty for over 30 years. She received her PhD in biochemistry and her MD from Tulane University, and she is the current chair in the Department of Dermatology at Tulane University School of Medicine in New Orleans, Louisiana. Her CV is so illustrious, we could spend the entire talk tonight talking about all of the amazing things she's done. One of the important things that I've been able to work with her on personally is serving on the board of directors of the American Academy of Dermatology. She's been intricately involved with the National Psoriasis Foundation, had numerous and countless textbook and article publications, and is again the Joseph Chastain Endowed Chair of Dermatology. Dr. Bowe, welcome and thank you for being with us. I'm looking forward to your talk on psoriasis and associated comorbidities. Erin, over to you.
Thank you, Samal. As Samal said, I'm going to talk a little bit about psoriasis and its associated comorbidities. So I want you to think about psoriasis and these comorbidities. I was late in getting my disclosures. I apologize, but here they are on my slides. So we all see these patients in clinic. They are psoriasis patients. They have manifested disease, not only as erythrodermic, some pustular. So they present in a myriad of clinical presentations, but they do share a lot of commonality. We'll see patients who are markedly obese, hypertensive. They may have arthritis, fatty liver, diabetes mellitus. We've seen them all. Now, why do some comorbidities cluster with psoriasis and others don't? I think if we think about psoriasis as an immune-mediated inflammatory disease process and not as an individual disease, we can kind of figure this out as we go along. In these particular types of diseases, cytokine dysregulation leads to chronic inflammation. And depending on the organ system involved with that chronic inflammation, we may see manifestations in the joints, in the gut, in the skin, all of which can contribute to significant morbidity, reduced quality of life, and in the case of psoriasis, for sure, and others, premature death. So as we go through tonight looking at these comorbidities, think about this little pathway. In psoriasis, we all are familiar with it. We know that there's increased levels of maybe IL-23, which shifts the Th17 cells into marked proliferation, and in turn, they secrete IL-17. We also see upregulation of Th1 cells, and those pro-inflammatory cells make inflammatory cytokines such as TNF-alpha, interferon gamma, all of which contribute to psoriasis. And they can contribute to other disease entities as well, just like we see here. So we see psoriatic arthritis, cardiovascular diseases, diabetes. They all, though, have in common systemic inflammation. So possibly if we direct our therapies towards knocking down inflammation, we can improve on all of these disease states. If you look at this PET CT here of a patient on my left who has psoriasis on no therapy, you'll see that there's a lot of hot spots. We see increased inflammation in the liver, in the skin, in the gut. You'll see it along blood vessels. You'll also see it over joints. But if you look at the little markers named D, that's skin inflammation. So all throughout the body, patients who have severe psoriasis have increased inflammation. That is a good target for our treatments. And if we look at the skin, primarily, we see pro-inflammatory cytokines like TNF-alpha, IL-1, IL-17. Those same cytokines may appear in adipose tissue. So we have obesity. In hypertension, so we have a peripheral vascular disease. All of those inflammatory cytokines set up an auto-inflammatory loop. So once they're kicked in, they keep propagating more inflammatory cytokines, more inflammation. And so we have a number of factors that can contribute to the clinical manifestations of psoriasis. We have this interplay with the immune system, we have environmental risks, we have genetic interplays where there's genetic permutations of the various genes that code for these inflammatory cytokines. We have upregulation of Th1 cells, Th17 cells, all of which contribute not only to atherosclerosis, to skin disease, but also cardiovascular disease. And as a consequence, we also see psychosocial events, events that can occur as a consequence of just having psoriasis. So as I said, in psoriasis, the interplay here of the inflammatory cytokines is primarily increased IL-17, IL-23, TNF-alpha. They cause upregulation of inflammation, proliferation of the CD8 cells, CD4 positive cells, which then accumulate in the skin, and as a consequence, proliferate, accelerate growth, and we get the skin manifestations of psoriasis. So if those cytokines are elevated, what's going on in other organ systems? Let's look first at the cardiovascular system. And we do know that psoriasis has an increased cardiovascular risk. We know that patients with severe psoriasis have an increased incidence of coronary artery disease. They have an increased likelihood of having a stroke, diabetes, they can have peripheral vascular disease. They have overall a 50% increased risk of mortality if their psoriasis is untreated. And additionally, if untreated, they can cut off as much as 5 years of life in a severe psoriatic. So there's significant consequences to not treating the skin. And we see in general, top causes of death in psoriasis right at the top, cardiovascular disease. Here we have a myriad of studies that show that psoriasis is an independent risk factor for cardiovascular disease. So regardless of the country you're in, regardless of other comorbidities, psoriasis serves as an independent risk for cardiovascular disease. So that's one we should think about when we see our patients with psoriasis. Now, why do they have an increased incidence of cardiovascular disease, of atherosclerosis? Well, if we look at the intima and we look at formation of atherosclerotic plaques, we see front and center inflammatory cytokines such as IL-17, TNF-alpha, interferons are upregulated. And so as a consequence of the increased levels of IL-17, TNF-alpha, you form this lipid-rich necrotic core, and you can form calcified plaques contributing to your atherosclerosis. So if we know that there's this inflammation, then can we address that by treating psoriasis? Well, there's a very nice study that looked at cardiac CT angiography. And what they found with that is overall, patients who had severe psoriasis had an increased prevalence of severe coronary artery stenosis. Okay, well, that's great to know. But the more interesting thing about this is they took prospectively patients who were biologic naive at the time that they started. They did CT angiography, got baselines of the lipid-rich necrotic core, as well as these atherosclerotic plaques. Then they put patients on various biologics, whether they were TNFs or IL-17 inhibitors. And after a year, they re-measured this using CT angiography. And what did they find? At the end of a year, they found that the non-calcified plaque burden was decreased by 5% in patients on the TNF alphas, but as much as 12% in patients who were on the IL-17 inhibitors. The IL-12/23 didn't have much impact, but it did slightly decrease that risk. So we do know that from this study that treatment of patients with biologics may improve coronary plaque disease by decreasing that lipid-rich necrotic core. And that's very important because that serves as a risk for cardiovascular events. And so by seeing just with a year of therapy, you can decrease that risk factor for patients who have psoriasis. And so we see here, looking at it, this is looking at it just a different way in the top part, part A, shows a change in the coronary plaque and at the end of a year, and the bottom one is the non-calcified plaque. But both of them showed a significant decrease in plaque burden after a year of therapy. And the therapy that was most impressive was the anti-IL-17 therapy. And there was a dramatic change in that in the non-calcified coronary plaque burden after a year. But the TNFs were quite good as well in decreasing this burden in patients who have atherosclerotic diseases. So from this study, and there's two other studies that actually corroborated the same event, we can say that the IL-17s for sure significantly decrease or reduce the non-calcified coronary plaque burden in patients who have atherosclerotic disease when treated with the IL-17 inhibitors. And similarly, the TNF inhibitors showed the same. Now, interestingly, while the TNF inhibitors showed a little bit less of a decrease in the burden, even non-biologics such as methotrexate did decrease that risk of cardiovascular burden. So just decreasing systemic inflammation can improve significantly patients' comorbid states. Now, another comorbidity that we see quite commonly in severe psoriasis is psoriatic arthritis. Enthesitis, dactylitis, axial spine disease are all very much seen in patients who have severe psoriasis. And with the initiation of enthesitis, that starts out with our innate immune cells, but they upregulate very quickly IL-23. IL-23, if you think about psoriasis, will in turn upregulate Th17 cells and subsequently increase IL-17 and TNF-alpha production. So we see here that IL-23, IL-17, and TNF are also integral in the formation of enthesitis. So patients with severe psoriasis, they have a much greater incidence of psoriatic arthritis. And in some studies, say up to 40%. If you look at all comers, mild to severe disease, that risk of psoriatic arthritis becomes lower. So mild disease, we don't see it as often, but severe psoriatics have a greatly increased risk of psoriatic arthritis, and probably due to increased levels of IL-17 and TNF-alpha in the joints. And here you see those two interleukins are the most significantly increased within the joint spaces, and they contribute significantly to joint disease. So let's think about the other comorbidities that I mentioned. Hypertension, for instance. Well, it turns out hypertension and coronary artery disease are mediated by TNFs, particularly TNF-alpha, but also IL-17. Obesity. Obesity is markedly associated with increases in leptin, but also copious amounts of TNFs are produced by fat cells, and that contributes to metabolic syndrome. Diabetes mellitus is mediated in part by IL-17. Hyperlipidemia, similarly, you see markedly increased levels of IL-17, you'll see increased levels of TNF. So you see that these comorbid states do have increased levels of the same cytokines that we see in the skin. So is it coincidence? Is it coexistence? Do these serve as independent risks? Or maybe throw them all together. And so if we're seeing these in our patients with psoriasis, the particular comorbid state can help direct our choice of therapies. So here you see a patient who has fairly severe psoriasis, put on an anti-TNF, 16 weeks later, skin looks beautiful. Follow-up corollary to biopsies, you see acanthotic skin and psoriasis at the beginning, and normalization of the skin to show normal skin, no psoriasis there after 16 weeks of therapy with a biologic. Now, do these therapeutic alterations in the skin, which results in decreased inflammation, inflammatory markers, also result in changes in our comorbid states? We're still trying to answer that question. My gut feeling is, of course they're going to. Why should they not, right? If we can suppress production of these inflammatory cytokines, it doesn't matter which immune-mediated inflammatory disease you're treating, they will go down. And so if you look at psoriasis and these immune-mediated diseases, we see that severity of disease is associated with increased vascular inflammation. We know with therapy, you can improve their PASI scores, improve the skin. We will see improvement in vascular inflammation as measured by our CT studies that have been done. We see decreases in inflammatory markers such as CRP, the ESR. We see significant reduction in MACE events in patients who are on biologic therapies. We see improvement in insulin metabolism and resistance. We see increases in sex hormone binding globulin, which has been a surrogate marker for insulin sensitivity. So we see improvement in those comorbid states. We also see reversal or improvement of endothelial dysfunction. And as I mentioned in the study a few minutes ago, we see that IL-17 inhibitors improve endothelial function, decrease that lipid-rich necrotic core, and improve atherosclerotic plaques in patients who have psoriasis, decreasing inflammation that will probably equate to decreasing morbidity as well as mortality. So we know that there are tons of medicines out there for psoriasis. And I tell my patients now, you are so lucky to have psoriasis now because we have a plethora of drugs that we can choose, right? But how do we choose? I like to go, first and foremost, I think about comorbidities. Why? If I can knock out two birds with one stone, lucky me, right? It's important to consider efficacy, onset, weight, and those things. But I think front and center, comorbidities are going to be your best bet in picking the best and most likely choice for a patient to improve those. Well, we still have a lot of choices. And this is a busy slide, but if you look at these and look at your psoriasis patients and then think about do they have PSA? Do they have Crohn's disease, cancer or a history of, obesity, heart disease? Those are very important things that we need to think about. So if we have one more prevalent than the other, we can go to the TNF inhibitors, especially if, say, arthritis is front and center, but they have some cardiac disease. We know the TNFs will be great on both of those, right? But say that patient with heart disease also has congestive heart failure or battles with that. Then we can look at the IL-17s because they would be great for arthritis as well. They would not be so good if the patient has concomitant Crohn's or inflammatory bowel disease, but they still will be quite good. And if they have congestive heart failure, the IL-17s are a better choice than the TNFs. Similarly, the IL-23s may do that. We're at a flux right now because we don't know. Those are newer agents, and they will be studied, and we will probably see the same effects as we do with the IL-17s, but that data is not there yet. So in summary, psoriasis is a chronic inflammatory immune-mediated disease process associated with significant morbidity, especially if not treated, and that morbidity extends beyond the skin. We see elevated risks of psoriatic arthritis, cardiovascular disease, obesity, insulin resistance, all those that we discussed before. So if we can recognize early the comorbidities associated with the patient who has severe psoriasis, we can potentially treat and improve both the comorbid state as well as the primary disease that we're treating. We know that life expectancy for patients with severe psoriasis is shortened. So if we can improve their skin, improve the other comorbid states by decreasing inflammation, we certainly will increase their life expectancy. So I think that in going forward, when you look at your patient with psoriasis and you say, oh, what am I going to put them on? Think about their other comorbidities and think about what would be in the best interest of the patient and what would be the thing that would improve overall their comorbidities as well as their psoriasis. Thank you.
Erin, thank you very much for that excellent presentation, and please make sure you ask your questions and get those ready for our Q&A panel. It's my pleasure to introduce our next speaker. Our next speaker is Dr. Sheetal Desai. Sheetal is the head of the Division of Rheumatology in the Department of Medicine at the University of California, Irvine. She has a particular interest in psoriasis and psoriatic arthritis. She's been actively involved in publication and clinical research. And she is also a member of the National Psoriasis Foundation, has been very active. So Sheetal, take it away.
Thank you so much for having me here today. Erin, that was a great overview you gave on comorbidities. I'm so happy to follow along. I will be talking about psoriatic disease and risk factors in people of color. I just want to give you an idea as I was preparing this talk and just searching the literature, on psoriatic arthritis with different ethnicities and races, the paucity of data that exists. So my PubMed search for psoriatic arthritis in Black patients, 50 results, which we all know is a very small number with the vast majority of literature that's available on PubMed. When I searched for psoriatic arthritis in indigenous patients, I got 7 results, of which only 1 or 2 were actually valid. When I searched for psoriatic arthritis in Hispanic, and I searched as well for Latinx, I found fewer results with only 6 papers, of which only 2 or 3 of them were actually pertinent. So I will actually just kind of focus this mostly on psoriasis because we do have a paucity of data when it comes to psoriatic arthritis and associated risk factors in people of color. But when we look at psoriasis prevalence, we all know that psoriasis affects approximately 3% of the US population, and up to a third of patients with psoriasis can develop psoriatic arthritis. Now, when we're looking at the 3% of the population that actually have psoriasis, and we break it down further, we see that the prevalence of psoriasis in Caucasians is the highest at 3.6%. And this is data from a colleague of mine, Dr. Armstrong, back in 2014. And it's probably one of the most up-to-date statistics that we have. So Caucasians in the US make up about 3.6 of our psoriasis patients. African Americans make up 1.9%. Hispanics make up 1.6%. Now, some of the differences may be due to genetics. We know that there is a genetic predisposition, especially in the Northern European ancestry, but thanks to the GWAS and all of the genes elucidated that have affiliations with both psoriasis and psoriatic arthritis, there are discoveries for genes such as an HLA gene that is actually important to the adaptive immune response in psoriasis and psoriatic arthritis that is actually increased and higher in patients of African American descent compared to Caucasian descent. So there is some work that still needs to be done on the genetics as it relates to psoriasis and psoriatic arthritis with our people of color. Also be aware that some of these differences in the decreased amounts of prevalence in people of color are also due to a lower awareness of psoriasis in patients of color and a decreased access to care. So now compared to Caucasians, Blacks and Hispanics with psoriasis have more severe skin involvement. They have a higher disease burden. They have a greater impairment on the quality of life. And even more concerning, in a study that was done in 2014 at multiple urban centers across the country, they found that patients that were Black compared to Caucasians had a lower use of biologic treatments for their underlying psoriasis and psoriatic arthritis. So 46% of Caucasians in these 4 urban centers across the country were on background biologics for treatment compared to 13% of Black patients. Now, the awareness of diagnostic differences in skin color truly begins with medical education. So here at the University of California in Irvine, my division and the dermatology division worked together to actually put this study together. The study was just published about a week and a half ago. And what we wanted to do is evaluate the representation of skin color in rheumatology educational resources. This was led by my senior fellow, Dr. Bay. He looked at the top resources that our rheumatology fellows use across the country, looked at the top 5 resources used for education during fellowship and for studying for the board exams. He evaluated all the images in all 5 of these resources and actually evaluated their Fitzpatrick skin type and categorized them into light if they were type 1 through 4, or dark if they were 5 and 6, or indeterminate. We had a wonderful faculty member from our dermatology division, Dr. Kraus, who validated all the images. And the sad thing is of the thousands of images that were actually reviewed and met study criteria, 86% of the images of psoriasis and psoriatic arthritis were found to be images of light skin, and only 9% of all the images reviewed were found to be of dark skin types. And when we're talking about psoriasis and psoriatic arthritis specifically, the percentile of images that were categorized as dark skin were 1 out of 66 images that were available to review, or only 2% of all the images that were viewed were actually categorized as dark skin. And we know that this does not match the diversity estimates of incidence and prevalence in this country. And you can see how the problem is if trainees, whether they're in dermatology or rheumatology or primary care, are not trained in how to actually identify psoriasis in people of color, you can actually miss these diagnoses. So psoriasis in patients, for example, of Hispanic ethnicity, their psoriasis may be less erythematous than what you see in our Caucasian patients, but more so salmon colored, like you can see in these two pictures. Now, when you're talking about our Black patients, their psoriasis might actually be more violaceous looking or more brown in color, and their scale can be more adherent or more thickened. So really our concerns are that projections show by the year 2045 that over half of the US population will belong to a minority group. And we know that there are health inequities in our country that disproportionately affect Black patients, Indigenous patients, and truly all patients of color. BIPOC populations have a higher prevalence of disease, increased levels of disease activity, and sadly, a lower quality of life. And it's very important to be aware of diagnostic differences in skin color, especially when the majority of our patients with psoriatic arthritis, about 70% of them will have pre-existing psoriasis before they're ever even referred onto rheumatology. And it's very important when implicit bias actually exists in our current curriculum with the eventual effects of patient care. So just showing you examples of clinical trials, phase 3 pivotal clinical trials in several of our biologics that are FDA approved for both psoriasis and psoriatic arthritis. What you can see is the percentage of patients that were not Caucasian do not match our diversity estimates in our countries. So we had 9% that were non-Caucasian in the adalimumab clinical trial. We had 9.4% in the etanercept and the ustekinumab clinical trial that were not Caucasians. We really need to work hard in increasing the numbers of patients of BIPOC populations that are actually representative in these clinical trials. And so based on our study that we published, we've talked about the need for a better collaboration between both rheumatology and dermatology, both regionally and nationally, to actually help work together to improve the representation of our BIPOC populations in both psoriasis, psoriatic arthritis, and overall with psoriatic disease. We need a task force to help identify and incorporate images from these marginalized populations into our educational resources. And we truly feel the best way to teach this in medical school residency and fellowship is by a juxtaposition, a side-by-side display where they can see what truly psoriasis may look like in a Caucasian patient compared to Hispanic, Black, Indigenous, other patients of color. And the deployment of future clinical trials in psoriasis and psoriatic arthritis really need to incorporate more patient populations that are representative of our BIPOC populations. I will go ahead and end here.
Well, thank you so much, Sheetal. That was an excellent lecture, and I hope everyone gets their questions and answers ready. And let's go ahead and tee up our next speaker. Our next speaker I have the pleasure of introducing is Dr. Tiffany Mayo. Dr. Mayo is someone who I've known for a very long time and is a rising leader and just a phenomenal dermatologist in skin of color dermatology. She's on faculty at my alma mater, UAB, in the Department of Dermatology, and runs the Skin of Color and Ethnic Skin Center. And Tiffany's going to talk to us about clinical challenges in skin of color. Tiffany, it's all yours.
Thank you, Samal, and it's a pleasure really to be a part of this very important discussion tonight. So I'm going to get started. These are just my disclosures, and I'll go over the objectives as we go. But basically, we're going to highlight some of those things that Dr. Desai just pointed out, and even Dr. Bo alluded to some of these things related to delayed diagnosis in skin of color patients. So we'll talk about some of those challenges and pitfalls. And then I'll end with some cultural practices just to make everyone aware of that may affect the way that conditions in skin of color present, and then also that may affect treatment success in these patients. So we went over psoriasis prevalence a little bit, but I'll just echo what Dr. Desai concluded with here, that skin of color patients more often present with severe disease. So that's something important when we think about the comorbidities that Dr. Bo discussed, as well as the psoriatic arthritis that is likely underreported in literature. So one of the biggest issues with clinical presentation and being able to clinically diagnose psoriasis in skin of color patients is that we don't see representative images, and it isn't until recently that this has kind of been highlighted in dermatology and in rheumatology, how important this is, because it's not on our radar as clinicians often, and so we're missing the diagnosis more than we should be. So I'll just start talking about the clinical findings. And so when we think about psoriasis and the way that it's described in our major textbooks, we think about bright red, well demarcated, thick, overlying scale. And that's just not how it's going to present in skin of color patients usually. So based on the patient's skin tone, you may see, instead of the bright red, you'll see more violaceous pigment. You may see more purple, gray, and deeper red colors to the typical bright red or salmon color that's described in literature. And also, one of the features that we commonly see reported in studies on prevalence of psoriasis in skin of color patients is hyperpigmentation. I'll also add hypopigmentation, as you can see in one of our patients here from UAB. But this is something that is unique more to skin of color patients, and so you may see it a little bit more often here. Post-inflammatory hyperpigmentation is a big concern of patients, and it is also something that I'll mention should be addressed as we're treating psoriasis, because it affects the patient's perception of improvement. One of the things that I've seen reported several times in literature for skin of color patients and psoriasis is the appearance of thicker plaques and scale. So I'm going to talk a little bit about that further in the discussion, but with the appearance of thicker plaques or scales, that could be related to just psoriasis and skin of color patients, or it could be related to the more advanced stage that patients are presenting with. So here we want to watch out for some things. So because psoriasis isn't necessarily a common diagnosis known to skin of color patients, patients may have tried treating this with something on their own before seeing a dermatologist. So watch out for overlying contact or eczematous dermatitis that can kind of create a little bit of a muddy picture when it comes to the classic presentation of psoriasis and skin of color. Also, there are other diagnoses to consider, lichen planus, discoid lupus, sarcoidosis, CTCL, to name a few, that are usually considered. I intentionally didn't put tinea capitis or tinea on this slide because that is typical, the default in this patient population when we're seeing plaques and scale. And even though that's also a common condition, I do want to kind of have us start thinking more about some of these inflammatory conditions that we know are commonly happening that we're probably misdiagnosing in skin of color patients. The other thing I'll say here is that, especially if it's a new patient who gets misdiagnosed, we in medicine assume that patients are going to follow up if they're not getting better. But if it's a new patient and their skin of color and they're misdiagnosed without setting the expectation that if you're not better, I need to see you back and know because I'm thinking about other diagnoses, then you may not see that patient again. And so that can affect some of those comorbidities and delayed treatment and diagnosis for this patient population. So don't forget a few little things. So the morphology is the same. We still see these well demarcated plaques in skin of color patients, but there are a few other clues that can help with the diagnosis. So geographic tongue is something that you can look for. Nail pits are often present. And then don't forget to ask patients about joint involvement. This is just to kind of second what Dr. Desai mentioned about the prevalence or the low reported prevalence of psoriatic disease in skin of color patients, probably having a little bit more to do with just underreporting. So I want to spend a little bit of time talking about site-specific psoriasis, because I would be remiss if I didn't talk about scalp psoriasis in this patient population. So scalp psoriasis is a highly prevalent phenotype of psoriasis in general. It is also a very prevalent phenotype of psoriasis in skin of color patients. Particularly the literature highlights that Asian patients may have a little bit more of this phenotype present than we previously thought. Seborrheic dermatitis is also, of course, highly prevalent, especially in patients of African descent. And so then we have this diagnosis of SIBO psoriasis that we describe as an overlap between seborrheic dermatitis and psoriasis. So I just want to caution here with SIBO psoriasis. It's clearly, a diagnosis, and sometimes it can be difficult to distinguish between psoriasis and SIBO psoriasis. But my caution is that don't delay treatment for someone who actually has psoriasis because they also have concomitant seborrheic dermatitis. Also think about what is it going to take for you to diagnose the patient with psoriasis if you saw this in a different skin tone. Would this meet your typical qualification? So just because a patient has seborrheic dermatitis overlapping with their psoriasis doesn't mean that they need lesser treatment or that you don't need to start thinking about joint involvement and some of those other comorbid conditions by giving it a title of SIBO psoriasis. So I want to take a look at this chart here, and we know that plaque psoriasis is very prevalent, but here this chart shows that scalp psoriasis in a prevalent study, I think this was 2016, scalp psoriasis was over 50% as well. So scalp psoriasis could be the presenting symptom or phenotype. It could be the only phenotype that the patient is presenting with. And so if we are diagnosing all scalp psoriasis in skin of color patient or misdiagnosing it as seborrheic dermatitis or SIBO psoriasis or tinea capitis, then we are missing an opportunity to treat these patients early. We're missing an opportunity to gain their trust in diagnosis. We're missing several opportunities here. So SIBO psoriasis definitely, is a diagnosis, but I just want to add that as a little bit of a caution here. I also wanted to talk a little bit about inverse psoriasis because it is something that is less common, but it accounts for 21 to 30% of psoriasis. And so it is difficult to distinguish this from intertrigo and contact dermatitis in all ethnicities, but particularly in skin of color patients who may have that baseline hyperpigmentation in flexural regions of the skin. This may be something that's difficult to diagnose. So patients may have a prolonged course of disease and actually, have some morbidity associated with that. So remember that inverse psoriasis and scalp psoriasis are conditions or phenotypes of psoriasis that really deserve our attention, and that can be the presenting phenotype for psoriasis in skin of color patients. So I just wanted to show a lot of times we do diagnose SIBO psoriasis, but using dermoscopy, you often can distinguish between the scale of seborrheic dermatitis and the scale of psoriasis. So here in this first image, you see a clinical of one of my patients with psoriasis, scalp psoriasis, and then this is actually a different patient, but you can see in the psoriasis dermoscopy image and compared to the seborrheic dermatitis dermoscopy image, In psoriasis, you see more of a fine white scale, often with a little bit of background erythema or violaceous color, whereas in seborrheic dermatitis, it's more of a yellow waxy scale. And unless it's very severe seborrheic dermatitis, you often don't see that background erythema. So this is the dermoscopy that corresponds to this patient. And she has quite a bit of scale and very, very minimal erythema. So you can use dermoscopy to help distinguish between seborrheic dermatitis and psoriasis sometimes. All right, so I'm going to end talking a little bit about cultural practices that can affect the way that psoriasis appears in skin of color patients. I'm going to highlight here scalp psoriasis. So scalp scratching is something that I do like to mention when I'm talking about psoriasis and skin of color. So this is a practice of parting the hair and then using a fine tooth comb to actually scratch along those individual parts, uplifting scale. So seborrheic dermatitis is such a common diagnosis in skin of color or patients of African descent that it's considered almost a normal thing to have this scale. And so scalp scratching or having someone scratch your scalp is actually a weekly or a very, very common practice. So this presents a problem for skin of color patients who may have scalp psoriasis. And so I just highlight this because it's important to counsel the patient regarding the Koebner phenomenon, because not only is this happening as a practice, so you can see me here, this is me scratching my grandmother's scalp. So it becomes almost a bonding experience because it happens so frequently. And I think I had just gotten back from college and I'm telling her some interesting story about someone or something. So it's something that happens all the time and patients are not aware that they can be worsening their condition. So you definitely want to talk to patients about it and counsel them against it, because when they're going to the beauty salons, scratching the scalp is done before they're getting their hair washed. So some studies talk about how scalp psoriasis is more severe in skin of color patients, and they think because it's due to seborrheic dermatitis, which is inflammatory, so it certainly can worsen it. But also think about some of the cultural practices that patients may be doing that they're not aware is worsening their condition. So when we think about religious beliefs where patients may wear scalp coverings, they also may have pins and things like that that can cause some focal irritation and worsening plaques. And greasing. So some studies, this is my daughter here going to town. So some studies show that scalp psoriasis or plaque psoriasis on the body will appear thicker and with more scale, but you actually may not see as much scale in certain patients if they're using petrolatum to cover the scale. And so don't expect to see that bright red or very scaly plaques that you typically would see in Caucasian patients, because you just may not see that based on some of the practices that the patient commonly will do. So I'm going to end with that for a time. Let's see here.
Tiffany, thank you so much. That was an amazing talk. I know exactly why we asked you to give that talk, and it's because you know how to deliver a great clinical presentation. So with that, we are at the halfway point of tonight's very exciting session. Thank you to everyone who's joined us. We have had a few questions come in. I've actually had a couple of people text me questions because they're so excited to be on tonight's session. So let's bring up our three phenomenal speakers, Dr. Erin Bowe, Dr. Sheetal Desai, and Dr. Tiffany Mayo. And let's dive into a couple of questions, and then we'll also have all of our speakers at the next Q&A be available should anything come from part one. And so let's dive right in. Erin, a question for you related to comorbidities, specifically metabolic disease. How do you counsel your patients you put on biologics, particularly those from underrepresented backgrounds that may be more prone to diabetes or hyperlipidemia or hypertension? What do you give them in terms of practical advice on their psoriasis related to these underlying conditions? So do you screen them? Do you send them to the PCP? Do you have the discussion? Some practical pearls.
I actually do like to screen all my own patients. And I do think that as dermatologists, we are first and foremost physicians, so we could do that. But if those of you who feel uncomfortable, you send them to the PCP. I do screening labs on most patients, getting fasting lipids, looking at the regular stuff. I like to get inflammatory markers. And I like to get all of those things because even on the first time I meet a patient, I tell them that psoriasis is not just skin deep. That it goes further, but we're not going to do anything much about those except go see what they have, get their skin under control first. And once you've got a bad psoriatic, I don't care what the color of the skin is, when you get them under control, they are happy and they're yours forever. So that's when I then start talking to them about if they're obese, we talk about weight reduction. We talk about, and I kind of ease them into it and say, you might be obese as part of your disease process. It's not your fault and something you can't help it. So then you've got a captive audience. So I do think it's important for us to screen, and it's easy. It's screening blood tests. You've got to get them if you're going to start a biologic. You got to get TB testing. You throw in a lipid, you throw in anything that you find is a risk factor. And I do get inflammatory markers. I get a high sensitivity CRP because why? That's really a nice marker for cardiovascular and family history. Ask them about their family history. Patients who have psoriasis and a family history of cardiovascular disease, if they have moderate to severe psoriasis, they are at much greater risk for developing coronary artery disease themselves. Less so if you have no family history. So it is important. So I first tell them, yeah, all of these things are associated with it. We'll get your psoriasis, your joints under control, and then we're going to work on the other things. I'm from New Orleans. I never tell them to quit drinking until their psoriasis is under control, because smoking, drinking are two things that are easy to get rid of, but not from the patient's perspective. So you really got to win them over by getting them clear, making them feel better, and then you hit them with the things that they don't like to hear.
Erin, I love that. And I love everything you said, especially the fact that we are all physicians first, and we're all here to try to do our best to treat the whole patient. So I really love that. That was great. Okay, Sheetal, question for you. And I love that I have a fellow Desai. I mean, I'm sure we're cousins somehow, but it's wonderful to have a Desai rheumatologist and a Desai dermatologist. So I'm biased, of course. And I love that you're part of our faculty. Question for you, and this is actually something that I have a challenge with, and I do skin of color all day long, which is diagnosing psoriatic arthritis in my skin of color patients. It's already hard enough to diagnose psoriatic arthritis as it is. And I see a lot of psoriasis, and I see a lot of psoriasis in skin of color, everything Tiffany said. But add that second layer of trying to get a good joint history, look at those joints, look at the nails. It's a challenge. Any pearls on diagnostic tips for psoriatic arthritis in skin of color?
It's a great point you bring up. I would actually say most people with psoriatic arthritis, rheumatoid arthritis, and I'm talking about Caucasians, they don't have erythematous joints. It's more joint thickening, swelling on exam. So it really depends on your physical exam skills. So from my perspective, I feel like patients, if they're not diagnosed with psoriasis early enough, they're not seeing enough professionals to be referred over to us. But by the time they're referred to rheumatology, regardless of the skin color, I can feel skin thickening over their joints. I can feel synovitis. When I evaluate for enthesitis, it really doesn't matter what their skin color is, because I'm evaluating for lateral epicondylitis, medial epicondylitis, Achilles enthesitis, plantar fasciitis, and the exam maneuvers really don't change based on skin of color. So I would actually say gout, for example, is an inflammatory arthritis that you tend to see a lot of erythema over the joint because of the inflammation. But with other types of inflammatory arthritis like psoriatic and rheumatoid, I don't rely on the color as much as I do actually on how the joint feels, palpation of the joint. So I actually don't think we miss people when they actually have psoriatic arthritis. I think it's the same regardless of skin color. It's just sometimes distinguishing, is it truly psoriatic arthritis? Is it someone in their 50s with early osteoarthritis? Is it a coexistent other type of arthritis? It's more that than anything else. I don't think the color actually changes my ability to evaluate their joints, thankfully. But I will say, because patients, once they're diagnosed with psoriasis, the dermatologists and the PCPs are a lot more sensitive to whether they have joint complaints to send them on to us and rheumatology. If they're not diagnosed with psoriasis from the get-go, they may not receive adequate care and early care for arthritis either.
Wow, great points and very well said. And it makes me very happy that I have rheumatology friends like you to refer these patients to, because I will admit, I see a lot of psoriasis. I'm probably not the best at doing those thorough joint exams because that's just not my wheelhouse. So it's great that we're having sessions like this where we really have our fortes, each in our derm hats and our rheum hats. So that's great. And last quick question, Sheetal, soundbite, do you order routine x-rays on hands and joints to diagnose psoriatic arthritis? Because someone said it's hard to pick up on x-ray, especially if you don't have a radiologist who knows how to pick it up, especially in early PSA. So x-rays.
So I get baseline x-rays. Now, we realize that not all psoriatic arthritis phenotypes are the same. You'll get some really aggressive ones that already have erosive disease from the get-go. Then you'll get other people that have more milder disease that even when you get x-rays, they're totally normal. We teach our fellows at our institution that regardless of how amazing the musculoskeletal radiologist may be, you have to read your own x-rays. So we look at our own x-rays, we look for areas of bone loss, we look for areas of bone proliferation. And honestly, psoriatic arthritis is a clinical diagnosis. So they don't absolutely have to have x-ray findings, but I do get a baseline because if things aren't progressing the right way, and I find that radiographically they're getting worse on their current therapeutic option, then I will actually change their therapy. So I do get baselines in my patients.
And Samal, could I jump in 1 second to say this? And I think, Tal, you hit it on the head. I get x-rays on a lot of people too, but when I send my requests to x-ray, I write in the comment section, patient has psoriasis, I suspect psoriatic arthritis. And I tell the radiologist, look for changes of enthesitis or that sort of thing so that you direct them. Because if you don't direct them, you get no evidence of bone fracture.
Oh,
and
you get, they don't have a fracture, and that's not what you wanted to know anyways.
But you need to tell them if you don't know them. And again, the radiologist has to be sensitive to it, but I put it on every one of my x-ray requests.
No, I think that's great. And I'll say in addition to radiography, we're all getting trained now in musculoskeletal ultrasound. I wasn't trained in my era, but all the fellows are getting trained.
They're doing it.
And it's amazing because we'll see the patient and they'll bring in the ultrasound machine and they'll say, there's totally enthesitis at the Achilles. Even if it's mild enough, though, I couldn't see it on exam. So I feel like the addition of ultrasound will actually help us find the really low levels of synovitis and enthesitis that we might miss on our physical exam.
That's great. And that actually also may allow more accurate diagnosis in the office early on versus delayed.
Yes.
Okay, Tiffany, question for you. And, I love the fact that you talked about different anatomical distribution. Have you heard of a variant of psoriasis more prevalent in skin of color called follicular psoriasis? I know I've heard of it briefly in the literature, but someone asked a question about follicular psoriasis. Any thoughts on that?
Yeah, I've heard of it briefly in the literature too. And I think the clinical photos look similar to like the follicular eczema that we see more common in skin of color patients. So as we're starting to diagnose and pay a little bit more close attention to psoriasis and skin of color, I do think we may start to notice some of those little nuances like we do in eczema and those types of conditions we think of more commonly in skin of color patients. The other thing, like in Asian patients, sometimes in the literature, it's described that they may appear with more of the guttate, smaller plaques or small plaque, psoriasis. And so I do think as we learn a little bit more about the presentations, we may start to find different phenotypes in skin of color patients.
That's great. And we do have a couple of more questions, but we're going to go ahead and move on to panel part 2. And then we'll regroup at the end and take the additional questions. So thank you, all three of you. Phenomenal way to start this session. Great lectures. I can't wait for the second half and to bring you all back for Q&A. So with that, let's dive into our next speaker. And it's my pleasure to introduce Dr. Neeti Goyal. Neeti is a board-certified rheumatologist She's trained in medical school at Jefferson Medical College in Philadelphia, and then at Duke, both in internal medicine and rheumatology. She's currently the chief medical officer at Abcuro and adjunct assistant professor of medicine at Duke University School of Medicine. And she herself has also suffered from psoriatic arthritis for the past 10 years, so certainly can give us her perspectives as a patient, and that is why she's going to speak about patient experience and unmet needs from a rheumatologic, dermatologic, and patient perspective. Neethi, welcome, and over to you.
Do you see it correctly on the screen?
Yes, it looks
Yes.
great.
Okay, great. Just wanted to make sure. So sorry, and I thought I was at the beginning, but I'm not. So patient experience and unmet needs. Thank you, Seemal, for that very kind introduction. So one of the things that I just want to highlight is equality versus equity in terms of healthcare. So everyone has a fair and just opportunity to be healthy. But as you can see from the slide, it's not the same as equality to talk about equity. And equity is more about making sure that people have all the right resources they need to get basically the same access and to healthcare and to be healthy. Sorry, again, not technically savvy. This is a quick slide. I'm not going to go through it all, but really, what are the things that drive issues related to equity, health equity? And there are multiple. And unfortunately, many of these things are more common in driving differences in delivery of healthcare and receipt of healthcare in people of color than they are in the Caucasian population. So, you know, speaking about the patient experience in terms of psoriatic arthritis, one of the things that's really important is to understand and how terminology is changing, but we are individuals, people, participants. We are not patients, we are not subjects, we are people that have a disease. And that applies to everyone, not just people of color. But how do we improve healthcare delivery for people of color? I think that's a big issue. How do we reduce bias and discrimination, as I talked about on the previous slide, and improve health equity? And then a big thing for me is how do we know if the data that are available in the public domain related to psoriasis, psoriatic disease, apply to us and our families? So I just wanted to bring this paper to your attention in terms of experience of discrimination within the US healthcare system. And I am a strong believer that unless the problems are made to come to light with data, that we don't then have the understanding with which how to address the issues. So not a lot of solutions are being provided here on my talk. I'm just really more pointing out the issues that have been found out. So in this one survey that they did of people just to see what their experience was with discrimination in receiving healthcare, 2/3 of the people who were sent surveys responded. Now, this survey is supposed to be done in a manner which reaches people regardless of their ability to access the internet. But the main way that they reach people was otherwise through the telephone. And we do know that people of color, again, if they're economically disadvantaged, if they live in rural communities, are less likely to have both access to the internet and the telephone. So one of the problems with a lot of the data that are out there related to people of color, as well as the minimal data that are out there, as Dr. Desai previously mentioned, related to psoriatic arthritis in people of color, is ascertainment bias. We may not be getting the data that we need and the people we need to get it because people are using the wrong sampling methods to get the data. Regardless, 20% of the people reported discrimination, with several experiencing discrimination on more than one interaction. In general, race was one of the most common reasons that people was one of the most common features for which people reported discrimination. But discrimination, when they did multivariable regression analyses, was more likely to be driven not by race, but female, low income, or poor to fair health status. So that said, how much race may play a factor in that is still unclear, because we know, again, even if race is not the driving factor, many people of color may be more likely to have low income or have more comorbidities, and thereby driving poorer fair healthcare status rather than good health status. As Dr. Desai alluded to, there's very limited data regarding differences in psoriatic arthritis versus people of color. But one study that was published related to people who were identified primarily for psoriasis and then evaluated too for the prevalence of psoriatic arthritis. In that set of individuals, Black patients or Black individuals compared to white individuals were less likely to have psoriatic arthritis, but those who had psoriatic arthritis were less likely to have minimal disease activity. They did have, in terms of differences of presentation, less dactylitis, fewer swollen joints, but they were also less likely to receive biologic therapy, as Dr. Desai already mentioned, and have more comorbidities. So I'll bring your attention to this very recently published paper looking across different types of insurance and different racial and ethnic groups in terms of evaluation for both prevalence of psoriatic arthritis, but also treatment and seeing a rheumatologist. So one of the things that wasn't commented on in the paper, but I found very striking, is if you look at the numbers or percentages by race that have commercial insurance or Medicare, the significant number of people that have Medicaid that are people of color. So people that, to have Medicaid, you typically have disability or you have low income. And so many more people percentage-wise had Medicaid versus the other things. And I think that that's really important in terms of the context that we're going to see the data coming up. So if we look at prevalence of psoriatic arthritis, as I've already pretty much stated, psoriatic arthritis was likely to be less common in people of color. And so, and that was regardless of the type of insurance that you had. So it was about half as frequent in people of color as it was in white people. And again, by insurance status, there was pretty much similar access to seeing a rheumatologist. So there weren't differences, but if you looked at individuals with Medicaid, then they had much less access to a rheumatologist or were much less likely to see one. And then similarly, people on Medicaid were less likely to get biologics or targeted synthetic DMARDs. Going back to the previous slide, which I highlighted, that more people with Medicaid, or more of the people with Medicaid were people of color, you can then make the connection that more people of color are likely to not get the treatment they need or see a rheumatologist. So I just wanted to bring that out, that I found that a very important piece of information that was not really discussed at all in the paper. The other thing about, as I mentioned, ascertainment bias is that although people may have access to Medicaid, there's always reasons that they may not. And there are more people overall that are uninsured if they are people of color. So that too is a big problem in terms of the data even available from that paper. So I'm going to switch gears a little bit because this is something near and dear to my heart, but clinical trial diversity. So I mentioned, how do we know that the data apply to us and why this matters? So people of color are historically underrepresented in clinical trials. So we can't always say, maybe based on genetic differences that have already been alluded to in the previous presentations tonight, that we don't know that people will respond similarly to the drugs that we have or have been approved for psoriatic arthritis. We need representation by people of color in clinical trials to know that the therapies that we're developing will work for them. And again, to assess potentially different reactions, both in terms of side effects as well as treatment response. And overall, that will improve healthcare delivery and equity overall. So we do know that overall there's underrepresentation in clinical trials. You see the population makeup of the US on the left, and you can see that the red and the blue is much less, indicating people who are Hispanic or African American. In terms of an analysis that I did of psoriatic arthritis studies, publications of randomized controlled trials that have been instrumental in getting our latest and greatest therapies approved for psoriatic arthritis. 4 of 22 of those trials didn't report race or ethnicity at all. There were no studies none of the studies reported anybody by Hispanic or Latino status. Black race was reported only in 7 of 22 trials and comprised horribly less than 1% of participants. And then Asian or other was reported in 11 of 22 trials. They comprised less than 10% of the individuals in most of the studies, but 12 of those enrolled in Asian countries, which of course would have increased the representation by Asian individuals in those studies. And representation by race or ethnicity was lower than that of the prevalence of non-white individuals in the US. What are some of the factors influencing diversity, equity, inclusion in clinical research? So participants who are actually getting enrolled, to some degree that's driven by where enrollment occurs and who that enrollment occurs by. If they're people who are white and see primarily white patients, then again, we do know that we have underrepresentation in our workforce. The workforce that exists does not reflect the population makeup of the United States. And so again, if people feel more comfortable with a physician who understands them better culturally or ethnically, then that access to healthcare may not be there. And then many of those people may not be investigators able to recruit patients to give us a diverse population. And to the point that I made previously, there are issues related to workforce diversity. And I think that that's a place for us to start in terms of trying to address health equity as well. And if you can see here, there are a significantly few individuals that are African American and physicians in our country, as well as Hispanic physicians in our country. And so if we can address some of those things, that may also help address some of the things that patients need to be better understood, aside from educating people, such as the previous talk did, which I had no idea about some of these things culturally that Tiffany presented, related to how different cultures may approach their disease differently. So in conclusion, psoriatic arthritis is less prevalent in people of color. Current sampling methods are also potentially biased, which gives us concerns about what data are being collected. There is likely underreporting of the true incidence of psoriatic arthritis in people of color. Trials of new therapeutics are not representing the people that make up the country, and healthcare providers need to have more racial and ethnic representation in order to potentially help improve health equity for people of color. Thank you. Just some resources, and I always allow for questions, but we'll put that in at the panel.
Well, Neethi, thank you so much for that excellent talk. That was really great. And I also have a particular passion for diversity in clinical trials, and I think we all share that. So I'm really glad you mentioned that, and I have an additional comment about that when we get to the Q&A. But we'll get back to that and get your questions ready if you're in the audience for Dr. Goyal. It's my pleasure now to introduce my friend and colleague, Dr. Junko Takeshita. Junko is on faculty at the University of Pennsylvania at the Perelman School of Medicine in the Department of Dermatology. She's assistant professor of dermatology and epidemiology, as well as a senior scholar in the Center for Clinical Epidemiology and Biostatistics. I've gotten to know Junko's work over the past several years, and I have also had the chance to interact in terms of the health disparities space, and she's really done incredible work, and also was the recipient of an outstanding new investigator award from the National Psoriasis Foundation and a Young Investigator Award from the American Academy of Dermatology. She's received grant funding from the NIH, the Derm Foundation, National Psoriasis Foundation, and the National Eczema Association. And today is going to talk to us about addressing racial and ethnic health disparities in psoriasis. Junko, welcome.
Thank you, Samal, for the kind introduction. And I want to thank my co-presenters for really setting the stage nicely for me to talk about racial and ethnic health disparities related to psoriasis and how we can address them. Here are my disclosures. And I also want to note that I'll be sharing some data that are not yet published in slides marked "Please do not distribute," and ask you to be mindful of these unpublished data. So before I talk specifically about psoriasis, I want to start by reviewing the definitions for health and healthcare disparities to make sure we're all on the same page as we discuss disparities related to psoriasis. And I always like to start with definitions because a clear understanding of what health and healthcare disparities are is so critical to properly identifying and ultimately eliminating them. So the first definition I want to present is the first official definition that the National Institutes of Health presented back in 1999. And in this version, they define health disparities as differences in the incidence, prevalence, mortality, and burden of diseases and other adverse health conditions that exist among specific population groups. And they specify in the US, but obviously health disparities happen globally. I also want to note that I will be talking specifically about US data today. Now, I think most of us consider the NIH to be a trusted source of information, and this definition may seem fine to some of you. Others of you may look at this definition, feel like something is missing. So let me present another definition to you. This next definition comes from the Healthy People Initiative, which is an initiative designed to guide national health promotion and disease prevention efforts in the US. And according to Healthy People, a health disparity is a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Now, the key point here is a health difference that is linked to some sort of disadvantage, which is so absolutely essential in defining a health disparity. So unlike what the original NIH definition suggests, not all health differences are health disparities. Now, one more definition that I want to present comes from Margaret Whitehead, who is a prominent figure in the health equity fields, especially in the United Kingdom. And she defines health disparities as differences in health that are avoidable, unjust, and unfair. And personally, this is my favorite definition because it's short, it's easy to remember, and really includes all of the key components of what a health disparity is. Now, moving forward, I'm going to be focusing on racial and ethnic health and healthcare disparities today in our short time together, but please know that there are many different types of disparities that are also so important to understand and address. Now let's define healthcare disparity. So the Institute of Medicine defines healthcare disparities as differences in healthcare access and clinical interventions experienced by certain groups that are not due to clinical appropriateness or patient preferences. And we care about healthcare disparities because they are one of many causes of health disparities. It was great that Niti talked about the social determinants of health because those are major causes of health disparities. Again, in the interest of time, I'm going to be focusing on healthcare disparities as we discuss causes of health disparities related to psoriasis. Just as not all health differences are health disparities, not all health care differences are health care disparities. If we think about the many potential causes of healthcare differences, we can categorize most of these into three broad categories as shown in this figure. Healthcare differences that are due to clinical appropriateness or patient preferences, those that are due to healthcare systems operations in the legal or regulatory climate, and those that are due to discrimination that can occur during the patient and healthcare provider encounter. Any healthcare difference that is due to clinical appropriateness or patient preference is not considered a healthcare disparity, whereas any difference that is related to the operations of healthcare systems or due to discrimination is considered a healthcare disparity. Now, one last thing that I want to present before we talk specifically about psoriasis is this framework for disparities research. As a scientist, I believe that research is central to addressing health and healthcare disparities in an evidence-based manner. So this is why I want to present this framework to you for disparities research that I follow in my own work and that guides my presentation of data to you today. Now, looking at this framework, it's on face value quite simple and presents a sequential process that starts with identifying or detecting the disparity. Once we identify a disparity, then we need to understand the causes of the disparity. And finally, once we understand the causes of a disparity, then we can develop targeted interventions or motivate changes in policy to ultimately not only reduce, but eliminate the disparity. Okay, so let's apply this to psoriasis now. Starting with the basic epidemiology of psoriasis, you've already seen these data multiple times today, so I know you're very familiar with these prevalence differences that have been reported in the literature across racial and ethnic groups. So as a quick refresher, these estimates come from population-based studies, and we see that the prevalence of psoriasis is highest among white individuals, as shown in this table, and is lower among Black, Hispanic, Asian, and other race individuals. Now, what I want to point out is that these prevalence estimates are mostly based on individuals having received a diagnosis of psoriasis from a healthcare provider. So they answered a question saying, yes, I have a diagnosis of psoriasis from a healthcare provider. So we're likely not counting people who have undiagnosed psoriasis. And this is important because some studies suggest that non-white individuals may be more likely to have undiagnosed psoriasis. So these prevalence estimates are likely an underestimate, especially among non-white individuals. Now, with regards to disease severity, you've already heard a little bit about disease severity. Unfortunately, there are very few population-based studies of psoriasis severity according to racial or ethnic groups. But the few data that do suggest do exist suggest that Black individuals in particular may have more severe psoriasis. But these studies had small numbers of Black individuals and certainly need to be confirmed in larger studies. And as you've already heard, there are also some clinic-based studies that have found that Asian and Hispanic individuals in particular present to healthcare with more severe psoriasis than white individuals. There's also increasing evidence that the quality of life burden of psoriasis differs by race and ethnicity. And you've heard some of this information already from previous speakers as well. Now, let me show you the data that this comes from. So for example, in work that we have done evaluating North American patients enrolled in the psoriasis longitudinal assessment and registry, we found that the quality of life impact of psoriasis as measured by the commonly used and validated Dermatology Life Quality Index instrument differed by race and ethnicity, where you can see here that Black, Asian, and Hispanic individuals each reported greater quality of life impact due to their psoriasis, as indicated by the higher scores compared to white individuals. And these differences persisted when we statistically adjusted for any differences in socioeconomic status, psoriasis severity, comorbidities, and treatment, as shown in the graph on the right, where again, Black, Asian, and Hispanic individuals were each more likely to report any impact on their quality of life due to psoriasis compared to white individuals, as indicated by the boxes above the dotted line at 1. So taking this all together, these data suggest racial and ethnic disparities in psoriasis burden among those who have the disease. Now, how might healthcare use and treatment of psoriasis among individuals of different race and ethnic groups contribute to these suggested disparities? With regards to healthcare utilization for psoriasis, in a US population-based study, we found that non-Hispanic minority adults with psoriasis had fewer outpatient visits overall and were also less likely to see a dermatologist for their psoriasis than non-Hispanic white individuals, as indicated by the blue box below the dotted line. And this disparity in healthcare utilization for psoriasis is likely to contribute to the differences in psoriasis burden by race that we just discussed. Not the only reason, but one of many reasons. Now, once a patient gets to a dermatologist, then what happens? To answer this question and evaluate the impact that a patient's race, gender, or socioeconomic status may have on a dermatologist's evaluation and treatment of individuals with psoriasis, we surveyed a random sample of over 3,000 dermatologists in the US and presented them with one of 8 survey versions that presented a 50-year-old person with psoriasis that has 15% of their body surface area affected, which is considered severe psoriasis. Each survey was accompanied by one of the shown headshots here and corresponding clinical photo of psoriasis. And each survey also differed only by race, gender, or socioeconomic status, one at a time. And the survey then asked dermatologists how confident they were in the diagnosis of psoriasis, how severe they thought the psoriasis was, and what treatment they recommended. Now, what we found with regards to confidence in diagnosis is that dermatologists who received the surveys with photos of a Black individual were less confident in the diagnosis of psoriasis compared to those who received the surveys that depicted a white individual. So 82% versus 97% of dermatologists who received the Black versus white survey respectively were confident in the diagnosis of psoriasis. And if the diagnosis of psoriasis is in question, then the treatment of psoriasis may be impacted as well. And again, you've heard about this data already. We know that there are racial disparities in treatment of psoriasis, specifically when it comes to biologics, which we know are the most effective therapies for moderate to severe disease. Now, this data that I'm showing you here come from a study that we did of Medicare beneficiaries with psoriasis. And we were interested in identifying the factors that are associated with whether or not a person with psoriasis receives biologic treatment. Now, a couple of our most notable findings were that 1, those who had higher versus lower out-of-pocket costs for biologics were less likely to receive a biologic treatment, as indicated by the pink bar. And I'm sure this comes to no surprise to anyone. But we also found that Black individuals were to a similar extent less likely than white individuals to receive biologic treatment, as indicated by the blue bar. And these findings were independent of other measures of socioeconomic status, insurance plan differences, and other health conditions, and have been further supported by other work that we and others have done in other patient populations. Now, upon identifying this treatment disparity, next we wanted to understand what's causing this disparity. And to answer this question from the patient perspective, we performed a qualitative study that involved interviewing Black and white adults with moderate to severe psoriasis who had and had not received biologic treatment in order to understand what their perceptions of biologics was. It was called a free listing exercise. We asked the study participants to list all of the words that come to mind when they think about biologics. And what you see here are the words or themes that we found to be the most prominent or salient among each group. The words are listed in order of importance, and the bolded words are particularly salient. Now, we found that specifically among Black adults who had never received biologic treatment, the themes of dislike needles and unfamiliar were salient and unique among this group, as shown in the blue circle and the pink box. Now, your first thought may be that, of course, these individuals are unfamiliar with biologics because they've never used them. But if we look at the prominent themes among white adults who had never received biologics in the yellow circle, we don't see unfamiliar. And rather, we identify words that reflect potential hesitancy about biologics and concern about side effects that indicate a recognition or understanding of biologic therapies. So these findings suggested to us that Black adults with psoriasis in particular may have less exposure to or may not be properly understanding that biologics are therapeutic options for them. Now, recognizing that direct-to-consumer drug ads are a major source of health and drug exposure and information for the general public, including for people living with psoriasis, we then wanted to know if Black and other racial ethnic minority individuals are adequately represented in direct-to-consumer ads for psoriasis. To this end, we performed a study of televised direct-to-consumer drug ads for psoriasis over a 2-week period in 2018, with a specific focus on describing the characteristics of the main characters in each ad. And in the table on the right, you can see a summary of the age, gender, and perceived race or ethnicity of the main characters in the ads. And what we see here is that non-white individuals are woefully underrepresented in these ads, with white individuals making up nearly 93% of the total number of main characters. So Black, Asian, Hispanic, and other minority individuals are unlikely to see themselves reflected in these ads, which may contribute to their lack of awareness that these medications are applicable to them. Now, to understand the healthcare provider perspective, let's go back to our dermatologist survey. As a reminder, we found that dermatologists who got the survey versions that included a Black person's photos were less confident in the diagnosis of psoriasis compared to those who received a white person's photos. In the same survey, we also asked dermatologists what their treatment recommendation was for this adult with severe psoriasis. And we considered appropriate treatment for severe psoriasis to be either phototherapy, any oral systemic, or any biologic. And when we evaluated the factors associated with recommendations for appropriate therapy for severe psoriasis, we found that lack of confidence in the diagnosis was associated with a lower likelihood of the dermatologist recommending appropriate treatment. So now we also have direct evidence on the impact that diagnostic uncertainty has on treatment recommendations for psoriasis. Now, putting this all together and applying what we know so far about treatment disparities for psoriasis back to the visual depiction of healthcare differences and disparities that I showed you earlier, we've identified a difference in the likelihood of receiving biologic treatment for psoriasis between Black and white individuals that suggests a treatment disparity. Some of the reasons for this disparity may be patient preference based on our qualitative study finding that dislike of needles was a salient theme among Black adults who had never received biologics. And if this is truly a patient preference, then this would not constitute a healthcare disparity. However, we also found that Black adults with psoriasis were less familiar with biologics, which may in part be due to less exposure to and recognition of biologics as treatments that are for them, as direct-to-consumer drug ads are targeting white adults with psoriasis. And additionally, we identified diagnostic uncertainty among dermatologists with regards to diagnosing psoriasis on darker skin types that may contribute to different treatment recommendations. So future efforts to address these potential causes of disparities are certainly needed, and these efforts may include specific interventions aimed at increasing awareness of biologics among Black individuals with psoriasis, such as development and use of decision aids, and increasing the diversity of characters included in direct-to-consumer ads. We also must address the diagnostic uncertainty among dermatologists by ensuring that skin disease education across the spectrum of skin types, not only on the trainee level, but also in continuing medical education among practicing healthcare providers. So in summary, health disparities are widespread and have been present for a very long time, including for psoriasis. For dermatologic diseases and psoriasis in general, we're really at the tip of the iceberg in terms of what we know about health and healthcare disparities. And there's still a lot that we don't know and we need to discover. And while much of the current work and research has been focused on identifying disparities, I really want to encourage our field to move beyond identification to understanding and eliminating disparities. So I'd like to end by acknowledging the people who have contributed to and the funders who have supported this work, including the National Psoriasis Foundation, and I look forward to our Q&A discussion. Thank you.
Junko, thank you so much. That was excellent. I've heard you give talks on healthcare disparities before, and it's always a treat. So I'm excited for our Q&A, and thank you again. It's my pleasure to introduce our next speaker. Our next speaker is Dr. Paras Kamacharya, who is an instructor in the Division of Rheumatology at Vanderbilt University Medical Center in Nashville. He's an active researcher in psoriatic arthritis and part of the Psoriatic Arthritis Research Consortium. He's also dedicated his career to understanding in both clinical and research realms outcomes in psoriatic arthritis and better treatment and diagnostic strategies. He did his rheumatology fellowship at the Mayo Clinic, followed by his postdoc and master's in clinical interest translational science from the Mayo Clinic on psoriatic arthritis research. He's the recipient of multiple grants, and it's really a pleasure to have him here today for an exciting talk on the fact that we have a lack of prevalence data in the BIPOC population related to access of care. So Paras, welcome, and thanks for being here.
Can you hear me okay?
Yeah.
Perfect.
Okay, sorry about that. Yeah, so and thank you, Dr. Desai, for that kind introduction. And good evening, everyone. And thank you to the National Psoriasis Foundation and the organizers for inviting me for this talk today. I will be talking about lack of prevalence data in Black, Indigenous people of color, access to care. And I do not have any disclosures. These are the objectives for my talk today. I hope that by the end of this short talk today, we will be familiar with race and ethnicity data in psoriatic disease, some of which has already been emphasized by excellent talks before me, and summarize healthcare disparities and then describe approaches to improve healthcare equity for psoriatic disease. Let's start with what we know about the epidemiology of psoriasis and psoriatic arthritis in different racial and ethnic groups, as highlighted by excellent talks before me. So psoriasis is more common in the white population. Similarly, the reported prevalence of psoriatic arthritis ranges from 0.1 to 1% in the general population around the world. Population-based studies in the US report the prevalence of psoriatic arthritis from 0.18 in our study from the Olmsted County, Minnesota, to 0.25% in self-reported data. And prevalence estimates in Europe range from 0.05% in Turkey and Czech Republic to 0.21% in Sweden. Unfortunately, only a few reports of prevalence of psoriatic arthritis in South America and Asia exist. And these studies suggest that the prevalence is lower in these regions, such as up to 0.02% in China. Now, while the discrepancies in the prevalence of psoriatic arthritis among these studies is likely related to differing definitions of psoriatic arthritis, for example, use of ICD-9 codes or medical codes versus use of classification, clinical classification criteria, studies suggest that lower prevalence of some of these regions, such as Asia, are due to underdiagnosis. Now, unfortunately, there are no large-scale studies on the prevalence of psoriatic arthritis in the US, stratified by race, ethnicity. This small study by Kerr et al. From Dermatology and Rheumatology outpatient clinics at 4 urban academic institutions showed that psoriatic arthritis was less frequent in African Americans compared to Caucasians, so 30 versus 65% respectively. The same study also showed that comorbidities were higher in African American patients with psoriatic disease compared to Caucasians. And as we can see in the table here, that cardiometabolic comorbidities, including diabetes, hyperlipidemia, and cerebrovascular accident, were significantly higher in African American patients compared to Caucasians. Similarly, this study from the IBM Explorers platform, including 26 major integrated healthcare systems in the US, this was recently presented at the ACR by Dr. Magri's group, also showed similar results. So in this study, also cardiometabolic comorbidities, namely hypertension, diabetes, obesity, and gout were more prevalent in African American patients with psoriatic arthritis compared to Caucasians. And so was uveitis. And interestingly, malignancy, osteoporosis, and anxiety were more prevalent in Caucasians. Now, why is this all important? So we know that comorbidities lead to increased morbidity. In addition, it also leads to increased mortality in psoriatic arthritis. Our systematic literature review on this topic showed that while overall mortality in psoriatic arthritis was not significantly higher compared to the general population, cardiovascular, respiratory, and infection-related mortality was significantly higher in psoriatic arthritis. And while we don't have any data on psoriatic arthritis mortality stratified by race or ethnicity from the US, studies from different geographic locations provide some insight. Now, this is our unpublished data from systematic literature review on mortality in psoriatic arthritis stratified by geographic locations. Mortality was significantly higher in the Asian population, but not in studies from Europe or North America. Now, it's unclear if the results represent environmental or genetic differences, or is simply a detection bias with underdiagnosis, with only severe psoriatic arthritis cases being diagnosed. Now, supporting this notion is this study from 2 hospitals in Northern England, including a total of 58 South Asians and 48 Northern European patients. Now, South Asian patients had more severe clinical phenotype, as we can see in the bar chart here, with more tender and swollen joint counts, more severe enthesitis, dactylitis, and more severe skin disease, as represented by the PASI score here. They also had worse disease activity as measured by the composite index and PASDAS, or psoriatic arthritis disease activity score. With regards to patient-reported measures, South Asian patients had worse impact with poorer quality of life and function, represented by the mean HAQ, worse mean HAQ scores, mean psoriatic arthritis quality of life index, as well as the SF36 scores here. US-based study from Kerr et al. Also showed higher disease burden in African-American patients. In the study, African-Americans had more severe skin involvement, greater impairment in quality of life, and psychological impact. Now, there was also numerically lower number of patients that attained psoriatic arthritis, minimal disease activity, or MDA, but this was not statistically significant, and possibly due to lower number of psoriatic arthritis patients in this study. Additionally, a retrospective study from psoriasis patients on etanercept treatment during phase 3B or 4 in the psoriasis trial found that Asians and Latinos have higher body surface area, 41 and 33% involvement compared to other ethnic and racial groups. Now, interestingly, in this study, the dermatology life quality index scores were worse for Latinos compared to Caucasians, 15 versus 12, even when controlling for body surface area. Now, why is this all important? Now, Dr. Takeshita spoke about the diagnostic challenge, and others spoke about the diagnostic challenge in people with darker skin tone here. Similarly, we know that for patients with psoriatic arthritis, the disease often undergoes underdiagnosed with diagnostic delays for years. And this is our data from Olmsted County with 90% white population. And even here, we see that majority of patients with psoriatic arthritis were diagnosed more than 2 years after symptom onset. And data from other diseases such as rheumatoid arthritis and lupus show that this delay may be higher in certain racial and ethnic minorities. So we certainly need larger, more inclusive cohort studies with long-term data in this regard. We talked about what we know regarding the epidemiology of psoriatic disease in ethnic minorities. Now, what do we know about access to healthcare in patients with psoriasis and psoriatic arthritis? Here we are seeing data from the National Psoriasis Foundation survey from 5,600 patients from 2003 to 2009 and 2011. And not surprisingly, the authors noted that patients with Medicare, or third-party insurance had significantly greater odds of seeing a specialist compared to patients without insurance. And patients with severe psoriasis were more likely to see a specialist for care compared to those with mild disease. This is important because we know that racial minorities are more likely to lack health insurance than their white counterparts, and therefore less likely to seek care. And here we are looking at data from 2019 community survey showing that racial minorities remain less likely to have any kind of insurance compared to whites. And delving further into healthcare access, so this cohort study of psoriasis patients, as described by Dr. Takeshita from 2000, so this study included patients from 2001 to 2013, medical expenditure survey, and it showed that non-Hispanic racial minorities reported fewer ambulatory visits and also were 40% less likely to report having seen a dermatologist for psoriasis than non-Hispanic whites. And data regarding healthcare access in psoriatic arthritis is somewhat sparse. Here we are looking at cross-sectional data from a US claims database from 2006 to 2019, showing the patient journey through different providers 6 years prior to psoriatic arthritis diagnosis. As we can see here, patients visit many specialties before having a diagnosis of psoriatic arthritis, and the overall frequency of referral to rheumatologist in the US was found to be low. For patients with commercial insurance or Medicare, the proportion of patients with psoriatic arthritis visiting a rheumatologist were similar among race and ethnicity groups, while for patients with Medicare, the percentage were slightly higher for Black and white patients compared to Asian and Hispanic patients. Important to note that the study doesn't include uninsured patients, as Dr. Goel earlier pointed out, and it is possible that certain group of patients are seeing a rheumatologist later in their disease course. Now, what about the use of medications? Despite the fact that in general, ethnic minorities seem to have more severe psoriasis and psoriatic arthritis, the use of biologics is not higher as one would expect. This is data from WashU with 4,400 psoriasis patients showing that the use of biologic therapies denoted by the orange bar here was significantly higher in Caucasians compared to African Americans and other race categories. On the other hand, use of topical therapy was significantly higher in African Americans. And there was a trend towards higher use of conventional DMARDs in African Americans and other races compared to Caucasians. In the same lines, this large study from the IBM Explorers platform also shows treatment differences among racial groups. TNFs were used in 51% of Caucasians versus 41% of African Americans. And conventional DMARD use was higher in African Americans. So clearly, we see that there is a lack of, there's a need for more research. And so what can we do going forward? Now, first, we certainly need more disease awareness and education regarding subtleties in presentation in ethnic minorities and providers, but also among patients, as highlighted by the presentations before me. And we need more representation of these groups and diversity in our cohort studies and clinical trials. Also, we need to further investigate healthcare access and barriers in these groups and ways to improve them. And finally, we required an improved understanding of factors associated with disease burden and quality of life, which seems to be disproportionately worse in certain groups. In our path to individualized medicine in psoriatic disease, I think it's very important to understand the impact of race, ethnicity, together with other social determinants of health, which together could play a significant role. So in conclusion, ethnic minorities have more severe psoriasis, higher prevalence of comorbidities, and higher disease burden. And despite this, certain ethnic minorities are less likely to be on biologics. And systemic health disparities, such as delayed health access, likely underlie this trend. So we certainly need a deeper understanding of these factors to improve psoriatic disease outcomes. Finally, I want to acknowledge some people who have helped me along this way and are responsible for everything I know about research and psoriatic disease. I want to thank my mentors, my research team, and my funding for allowing me to continue my research. Thank you very much.
Paras, thank you very much for that great talk.
Seem to be having some technical difficulties, but thank you so much to all of our faculty. And I think we are ready for the second Q&A panel. Let's just give Dr. Desai a second to get back on here.
Thank you very much, Shiva. I'm having slight technical difficulties.
Wow.
I feel like we should have some on hold music playing.
Can everyone see and hear me now? Is that better?
Yes, yes.
Well, this is always the fun part about doing virtual meetings, is the joys of technical AV difficulties that I'm sure we all experience. But I want to thank Paras, Junko, and Niti for those excellent talks. And we do have a few questions if we can get started with that. Niti, we do have a question for you specifically related to your interest in diversity in clinical trials. Could you talk a little bit about specifically any tactics that industry and physicians could use to enroll more patients of color and make this tangible become a reality?
Thank you. I think that's a great question. And I have thought long and hard about this and continue to. So I mentioned the issues related to workforce. I think that aside from workforce, we need to do a better job of training individuals that may have diverse patients or more diverse patients in their practice to be investigators. So I think that that's one thing. They may not have that access. And a lot of times we go to the same investigators over and over when we run a clinical trial. And so, and it's very hard now to sort of break in as a new investigator if you don't have someone bringing you into that fold already. And so I think that that's one piece of it. I think the other thing that we've tried to do is reach out in different ways. So go into the communities where these people of color or of maybe a bit more disenfranchised individuals may be. There are also things that you can do in terms of access. If, you know, many of these people may be holding jobs or have issues with childcare. So if you can provide things like childcare, if you can have evening hours or even weekend hours for the conduct of clinical trials, that may also help significantly in terms of access. The other thing that can help in terms of access is having culturally and ethnically based materials that speak to the thing. So Dr. Takeshita indicated how, there may be differences in beliefs related to what a patient may or may not want to do. So making sure that you address those in language that they can understand. Dr. Mayo also provided differences in terms of cultural approaches to care. So again, addressing those kinds of things and improving the education. And then, as was also mentioned in several talks, increasing the representation and increasing the education of people that people of color do have these diseases. And so if they get diagnosed, that they then have the opportunity to potentially enter a clinical trial. So that's another way too. And in some ways that might be the low-hanging fruit to some degree. I guess Seema was having more technical difficulties.
All really good suggestions you made. I love it. At UCI, we have a huge Hispanic patient population. So what we had done is in one of the clinics, we had actually given them a questionnaire and just a survey asking what their barriers were. So I could figure out how to pitch it to the pharmaceutical companies. And if they wanted more enrollment, we would need help. And it did actually come down to transportation, childcare, and evening hours, exactly what you had said.
Neethi, and thank you so much for that really great answer. Junko, a question that we actually have for you, specifically related to going back to the health disparity versus healthcare disparity distinction you made. How do you view that from a practical perspective for, let's say, a dermatologist or rheumatologist? Is that something that's more disease state based? Could you just recap how you'd like to split those up in our minds?
My purpose in really presenting those definitions is to make sure that we all understand, that not every health difference that we see is a disparity. And it's so important for us to know what health differences are disparities and what are not. So if I give like a very simple example of, for example, we see different prevalences of non-melanoma skin cancers in different racial ethnic groups, that's really mostly biologically driven due to skin pigmentation and different associations with UV protection, for example. So when a health difference like that is primarily biologically driven, not mostly associated with some sort of social or environmental disadvantage, then we don't consider that health difference a disparity. And so similarly with healthcare disparities, we want to make sure that anything that is sort of clinically appropriate healthcare differences or treatment differences, those differences are not healthcare disparities, and those are not the ones that we should be targeting to try to understand why they exist and intervene. So that's my main purpose, to make sure that we're really driving and focusing our efforts on addressing those differences that are really disparities, because those are the issues that we need to tackle.
I love that. And I think all of us would echo that, especially on this call, and I'm sure many in our audience as well. Paris, you get the last question. Thanks for your excellent presentation on the lack of data and the fact that we need more data. Can you describe some specific ways in which there can be more collaboration between physicians in various specialties who treat psoriatic or psoriatic arthritis to really get more of this outcomes data that you referenced?
Yes, thank you for the questions. So yeah, I think certainly with Pac-Man and with the National Psoriasis Foundation, we're sort of looking into more of a derm room collaboration in clinical practice as well. I have personally in practice, I think there are certain things that might be in way of that, like logistically. But there are ways to sort of get around that. And one of the things is certainly a virtual collaboration, and that's what I've been practicing, trying to practice at Vanderbilt also. So when a patient being referred to me by a dermatologist comes to me, then I discuss the case with a dermatologist before I actually make a switch in the medication. So that could be at the time of the visit, if they are actually available in the hospital or the clinic, or through Epic, where I would send them a message and trying to just make sure I communicate with them very well. And I think that goes, that also applies to other specialties, and we're seeing more and more of psychiatric illnesses such as mood disorders in patients with psoriatic arthritis. And so just communicating with the primary care providers and the other specialties such as psychiatry or cardiologists. So just trying to communicate with them and just treating the patient as a whole in front of you, as like an individualized patient in front of you, taking all these factors into account. I think that's the way to go in the future.
I think that was very well said, and I couldn't agree with you more. That multidisciplinary approach is really something that we really want to continue focusing on. The past 2 hours have just flown by. We're already at our end of our session. This has been an amazing, amazing set of lectures. I want to thank Erin, Junko, Niti, Paras, Tiffany, Sheetal, all of our amazing speakers. Thank you so much for being with us today. It's been an honor. Thank you, Paras, for leading us and with those great questions and great answers. Thank you to each of you for your research and for sharing your contact information for our panelists. And special thanks to Stacy, Shiva, and the entire NPF for allowing us to put this together. All of us are on social media. Please feel free to follow us. I want all the speakers to put their Twitter, Instagram tags in the chat so everyone can follow the amazing works you all are doing. And hopefully this is the first of many continued collaborations on the need for skin of color. With that, I want to thank you all for attending. It's been my honor to serve as your moderator. Thanks for bearing with our few technical difficulties. Hopefully the next time we do this, we can do this in person. That was the initial plan earlier this year, was to have this meeting live and in person, but this was a fantastic way to get us started. And I look forward to future opportunities to interact with all of you. Thank you. Have a wonderful evening. Good night.
Good night.
Good night.
Thank you all.
Thank
Thank
you.
you.
Good night.
Bye-bye.
Bye.
Thank you. Thank you,
Bye.
Simone.